Good day and welcome to Epstein Becker Green's webinar, Overview of Value-Based Payment Efforts under Medicare, the first installment of our Value-Based Payments Crash Course webinar series. We are pleased to have Epstein Becker Green's Helaine Fingold, who is a member of the Healthcare and Life Science practice, presenting today. Before we begin today's webinar, please be informed that the webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are also welcome to submit questions directly to Helaine following the webinar. Unfortunately, there will not be enough time to answer questions during today's webinar. In approximately 2 to 3 business days, Epstein Becker Green will communicate the availability of the recording and access to the PowerPoint materials. At this time, I'd like to turn the webinar over to Helaine.
Hi, good afternoon, everybody, and welcome to the first in our series on the crash course around value-based payments. And today I'm going to be speaking about the Medicare value-based payment initiatives. Medicare's been testing in this area for a number of years, and I'm sure you've heard about a lot of the different ones, so I'm going to try and at least give you a brief overview of the variation. And these are certainly areas in which lots of the private payers and other entities are looking to Medicare and to see how they're doing and what they're doing as they move forward in the private sector and others. So let's move into the bundled payments first. Thank you, Lisa. So bundled payments for care improvements initiative, BPCI, incentivizes providers looking to take accountability for both cost and quality, which I think is kind of standard on most of them. The 4 models of the BPCI, the first model was just looking at the acute hospital stay and really was just an intro into the other 3 models. It was very kind of confined, and I think there's only one entity that's still in that model. So the second model, again, they're tweaking to see what works better, retrospective acute care, hospital stay, and adding in the post-acute to the bundle, again, so that if there's issues and there's readmissions, the hospital is responsible for that. Then they're doing just the post-acute, and then the fourth where it's prospectively based, acute care hospital stay only. So those last 3, the second 2, 3, and 4 are still operational. 1, again, there's just one entity that's still operating on that model. CCJR, Comprehensive Care for Joint Replacement, is a recent program that started, began effective this last month, I guess now, April 1st, 2016. It was significant in that it was mandatory, something that hasn't often or always been the case with other programs. So anybody in the select markets that's offering the lower extremity joint replacement is on a bundled payment, retrospectively resolved, and the hospital, again, is accountable for quality and cost, going to 90 days post-discharge, including all related A and B services. Let's go to the next page on, so hospital-specific initiatives. These are several that have been around a little bit longer and are more, I guess, if you're thinking of things on the carrots versus sticks or somewhere in between there, I think these are probably a little more on the sticks versus the carrots. The readmission reduction program is one where CMS is looking at a hospital's excess readmissions. So what is an excess readmission? So they're kind of comparing the hospital's experience on readmissions against other hospitals nationally over the 3-year performance period. There is risk adjustment to address, obviously, different hospitals have different groups of individuals, the different income levels, different health status, all different kinds of things, and they are risk adjusted. Based on performance over the period, the estimate is that 78% of hospitals were penalized or will be penalized under this program, and 1.2% of the hospitals will be penalized the maximum rate of 3%. The average hospital penalty among the penalized hospitals is estimated to be negative 0.63%, and that negative 0.63% totaled approximately $428 million. Hospital value-based purchasing, so it's funded through a 1.75% reduction from the hospitals, the participating hospitals' base operating DRG payments, and then redistributed based on quality on the performance scores. So the actual amount earned by each hospital obviously is going to depend on the range and distribution of all eligible hospitals' scores, and the hospital can not only earn back the money they put in, they could earn more, but they actually could also earn less, right? So they might have put some in and get some back, but still be at a loss. The hospital-acquired conditions reduction is looking at conditions that are a secondary diagnosis that a person didn't have upon admission that could reasonably have been prevented. So they're looking at the admission to determine whether, again, the condition was present. If it wasn't present and then the person has it after they discharge or in the hospital they get it, then the hospital is paid as if that secondary diagnosis weren't there. So the secondary diagnosis increases the payment because it just results in a higher cost, higher volume for the hospital. So they're not getting rewarded for that second condition. Let's go to the next one. So now the next, I guess, bucket of initiatives, and I was trying to sort of separate them out in a way that made sense to talk about in a short period of time. Post-acute care, looking at post-acute, not in conjunction with the hospital services. There's a skilled nursing facility value-based purchasing program, which is under development. It was required by Congress under the PAMA, Protecting Access to Medicare Act. It's a little similar to the hospital readmission because it's looking at hospital readmissions, but it's because after the skilled nursing facility visit. So it's going to be, right now it's initially including an all-cause, all-condition readmission. They're going to change it to look more like the hospital approach where it's going to be risk-adjusted, potentially preventable readmissions, and again, it's an increase or a decrease based on the quality measurements. Also a home health value-based purchasing, which provides, again, an up or downside of up to 8% based on performance on quality measurements, also against peer home health. So let's move to the next one is the primary care initiatives, and in fact, one is relatively recent. People are hearing right now about the physician payment changes that are just being discussed. Right now, there is a physician value-based payment modifier under development. It was required through the ACA to be applied to payments for 1/1/2017, next January. Allows, again, for differential payment based on quality of care. It's a comparison. They're looking at the fee-for-service beneficiaries at the cost during a performance period. However, in 2019, and as some of you may have heard, CMS was just having a webinar to discuss its MACRA rule that just came out. The value-based payment modifier is going to be replaced by MIPS, the Merit-Based Incentive Payment System. So MIPS kind of brings together a number of initiatives that CMS has been pursuing, the quality reporting, the value modifier, the EHR incentives together so that the professionals, and it's not just physicians, it's providers, will be measured across quality, resource use, clinical practice improvement, and meaningful use of the certified technology. And so we're going to be hearing a lot more about that. Let's go, yes, thank you, Lisa. So it's oncology care model. Another sort of primary care, outpatient care, is looking at the 6 months of the episode of chemotherapy and related services provided, is trying to improve care coordination, appropriateness of care and access, and also to decrease unnecessary services. They're doing a per beneficiary per month payment. So you get a per member per month, sort of a per member per month for the episode, but also a performance-based payment that's based on quality measures. Comprehensive primary care initiative, and this is one in a series of different kind of primary care focused initiatives that look at population non-visit based care management fees, but also provide like a shared savings opportunity to participating practices to support them in providing a core set of what they're considering to be primary care functions. And let's see, primary care. So the Comprehensive Primary Care Plus is a national, it's advanced primary care medical home model. It's also trying to strengthen primary care. It's using a regionally based multi-payer payment reform and care delivery transformation. It's got two tracks. One is incrementally advanced care delivery requirements and payment options to meet the diverse needs of primary care practices. It's going to give greater financial resources and allow additional flexibility to make investments to improve the primary care, the quality and efficiency of primary care delivery. Thank you. So Independence at Home is tailored to chronically ill patients. Beneficiaries. Participating practices are going to give home visits. They're actually tailored to meet the needs of individuals with multiple chronic conditions and functional limitations. And again, there's quality measures to meet them and hope to generate savings, and they can get an incentive based on the savings and meeting the quality measures. So it's going to test to hopefully that home-based care can reduce the need for hospitalization, improve patient and caregiver satisfaction, and lead to better health and lower costs for Medicare. The ESRD, Comprehensive ESRD care model, there's a kind of a coordination across a number of entities that come together to coordinate care for the people receiving ESRD services. So it's dialysis clinics, nephrologists, and other related providers are coming together to create what's called an ESCO, ESRD Seamless Care Organization, to coordinate care. They're, again, measured, accountable for quality and financial outcomes, looking at AB spending, including the dialysis services, and they are getting the savings or bearing losses, though a larger entity, the larger organizations, are able to bear a higher level of risk. So they can earn higher savings or bear higher risk compared to smaller entities. So then let's jump into the ACOs, which are probably the more famous talked about entities that Medicare has been pursuing. The Shared Savings Program, which was the initial kind of run into this area, it provided the two risk models. One was just an upside, the sharing of savings. The second allowing sort of both up and downside and calculating the savings or losses by comparing the expenditures to a benchmark, the CMS established benchmark. So, I should step back a little, say the accountable care is the alignment of different providers together to treat entities. At the outset, people were not assigned, the individual beneficiaries aren't assigned to the ACO, and certain models they're not assigned. The newer models are allowing for beneficiaries to be kind of enrolled and set or choose, to choose their ACO, which was not the case in the earlier models. So there's, again, playing with around the edges and looking at the participation requirements to see which are more effective and most effective. So the second model is the Pioneer ACO. It's similar to the shared savings, but did allow for higher levels of payment and risk, and then was allowing people to move towards fuller risk, towards full risk bearing. The investment model is one that has been, it's out there but not yet operational. They're testing the use of prepaid shared savings to encourage in the rural and underserved areas and encourage current ACOs to transition again to bear greater risk and hopefully greater savings potentially. Next slide. The last one is the Next Generation ACO, which is also not yet operational but is coming. They're supposed to start, anticipated to start this year. Those in the ACO, Next Generation ACO, will bear higher risk but be eligible for higher reward than under other current ACO initiatives. Allows the entity to accept graduated level of risk from a fee-for-service type to a capitation, and they might also be able to offer benefit enhancements to help them maintain the kind of allegiance of the ACO, of the beneficiaries, including access, for example, to home visits, telehealth, SNF services, and maybe rewards for receiving care from the ACO and certain affiliated providers. So Medicare is certainly out in front on a lot of these issues, and as you hopefully tune in over the next few weeks to hear what some of my colleagues are going to talk about in the commercial market, in the Medicaid market, a lot of them are following very closely to what the Medicare model is. And I hope, I think I'm running out of time, and I hope you've enjoyed this, and we'll tune in next week as my colleagues continue the discussion. Thanks.
Thank you, Helaine. This concludes today's webinar. In approximately 2 to 3 business days, we will share with everybody the PowerPoint presentation along with the recording. If you have any questions, please feel free to contact Helaine directly. We have a number of upcoming value-based payment crash course webinars this month, and thank you for attending.